Ureteric is in page number 269 according to John Murtaugh, and from my I am using adobe. So according to the citizen 659, this is John Murtaugh 8th edition. So we started ureteric comes under nephrology or kidney related diseases, right? So kidney colic is not a true colic but a constant pain due to blood clots or stone lodged at ureteric junction. Presence as severe it presents as true colic pain though due to stone movement, dilatation, and ureteric spasm. Um, so what are the main symptoms of ureteric colic? It is loin pain. So if pain is in the loin, then the stone is in the kidney. If kidney or ureteric pain, so there is a ureteric stone. And then strangry, which means stone in the bladder. Strangry, what does it essentially mean? Strangry is a medical condition that involves painful and urgent need to urinate, even if the bladder is empty or obstructed. So it is a sensation or a painful urge to urinate, even if the bladder is empty or obstructed. So this means the when the stone is in the bladder and the person gets the sensation or urge to urinate. So what are the clinical features of ureteric colic? So it is mainly seen in males from 30 to 50 years. So there is intense colicky pain lasting 30 seconds to 1 to 2 minutes in between. Um, so it begins in the loin, radiates around flank and to the groin, thigh, testicle, or labia. So, so kidney pain is here, which means stone in kidney. Um, right. So ureteric pain, it's the ureteric colic. So it starts in around the flank. It starts in the loin, radiates around the flank, and then to the groin, and then to the thigh and to the testicle or labia. This is the typical radiation of pain. It usually lasts less than 8 hours, and there may be. So, if a person comes with ureteric colic, he is in intense pain and he has nausea, vomiting symptoms due to the pain. So, that should be kept in mind. And intense pain. So, this is the diagnostic criteria, right? So, intense pain in the loin to groin plus microscopic hematuria is equals to ureteric colic. So if the question has this intense pain that is radiating from loin to groin plus microscopic hematuria, ureteric colic, it basically means ureteric colic, right? So this should be kept in mind. So what are the signs of ureteric colic, right? So what does the patient present with if he has ureteric colic? So he's restless because of the pain, obviously, and then he can be cold and clammy, tenderness at cost of a pimple angle, abdominal and back muscle spasm, and this is important, smoky urine due to hematuria. So this is, as we saw, microscopic hematuria, and then we saw loin to groin pain. These are the typical symptoms which can clinch the diagnosis. And then, what is the first diagnosis which we put up? If you see a ureteric colic case. So if a person comes with the symptoms of pain in the loin to groin and he has a smoky urine with microscopic hematuria. One more thing, microscopic hematuria is not hematuria which is not seen with naked eye is called microscopic hematuria, right? So how do we know that the microscopic hematuria that it is a case of microscopic hematuria? So if ever or whenever a person comes with such symptoms, the first diagnosis that should be ordered is urine microscopy. So a blood testing should, right? So if this shows microscopic hematuria, uh, blood testing strip, right? But it should be noted that the negative blood in the like the negative strip doesn't mean the calculus is not there. So, but this is the first diagnosis which you usually advise to a person with ureteric colic, right? So, urine microscopy, and then gold standard is non-contrast KUB-CT. So, this is the gold standard, and IVP is rarely used these days. And then plain X-ray can also be used for most stones, but there are radiopaque stones which are calcium oxalate and phosphate that can be missed in the plain X-ray. So the gold standard is non-contrast spiral KUB-CT. Ultrasound, but will exclude obstruction. So if you use ultrasound, it can locate a calculus, but the obstruction is not seen in the ultrasound. So what is the management? So here is a case where a narcotic addicted person is malingering to just to get the morphine and fentanyl for pain relief, which we usually give for pain relief, right? So if a person is malingering and to if you have the diagnosis in doubt that the patient is malingering, you can get the patient to pass urine in front of an examiner to test for hematuria, right? While awaiting the passage of urine, another person supposedly should be tried for pain. Okay, so routine management. For the first management, initial management, pain relief is our main goal because the patient is in extreme pain. So we can use morphine and fentanyl, and we should also suggest the patient not to take high fluids, especially IV fluids. So this can distend the ureter and aggravate pain. Uh, so usually the most cases second on patient can go home and then IVP is used on the next day. Pain can be alleviated by what should be limited to. An effective alternative method is nitrosamine, and these are not that important, at least for me. Consider an antiemetic for the vomiting, which we usually see. So vomiting, so vomiting may be present or may not be present. So usually the vomiting is present, so definitely you have to give antiemetic, right? And then okay, so what are the cases in which we should follow the patient or the outcome of the stone passing spontaneously. So if the calculus is less than 5 mm, most of the times it passes spontaneously. And if it is more than 7 mm, intervention will usually be extracorporeal shockwave lithotripsy or surgery. If the person passes calculus, he or she, yeah, so if the person passes calculus, he or she should take the calculus and bring it for analysis. So I repeat, IVP may be necessary if there is evidence of obstruction. Persistent obstruction can cause sepsis, so that should be noted. The cause of stone should be considered, such as hyperparathyroidism, which causes hypercalcemia and hypercalcemia, hyperoxaluria, and UTA. Fever with ureteric colic indicates obstructed and infected kidney, and it can also sometimes lead to acute kidney injury. So then, if it has led to the complication of AKA, management is different, and if it is simply ureteric colic, then the management is different. So you have to be aware of that. Um, so if the stone is more than, you have to refer the patient when the stone is more than 7 mm. If there is bilateral obstruction, gross hydronephrosis, if there is fever or UTI, which means infection. Um, Sorry. And then the pain doesn't subside. If there is type 2 diabetes, type 1 calculus, and if there is presence of solitary kidney, if in whatever case the patient has undergone a nephrectomy or the patient is born with only one kidney, so it is an absolute indication for referral. So that in case we don't want to risk the new kidney, right, or the only kidney, right? Sorry, we don't want to risk the only kidney that is present. So these are the important. And then prevalence facts about your lifelong incidence is 10%, recurrence 75 on typical age, pregnancy the risk factor for kidney ureteric urolithiasis, urinary tract calculi. It is more predominant in males than females. Fiber intake is important, and uh, low protein fiber, high fiber intake, and high water intake can prevent kidney calculi. So on from urinary supersaturation with calcium oxalate. So most of the calculi are of calcium oxalate, and then there can be uric acid in cases of gout, and then they can be cysteine, which are very rare. Infected calculi or stroide, which are of magnesium phosphate and ammonia composition. Stroide is magnesium phosphate and ammonia composition. Polycolic. Mainly because they're opioid and seeking drugs by deception. This is what I've been talking about. And the can call it an affect and this can be very powerful even for experienced. The CT would help in locate in such patients if not an appropriate agent would be ketorolac. So ketorolac can be given in case of patients who are dependent, opioid dependent. So in their cases, the usual doses of opioids may or may not work because of their dependency. So it is also better to give ketorolac than directly give them morphine or fentanyl. Recurrent urinary calculi. So if you see a case of recurrent urinary calculi, you check for electrolytes, urea creatinine, so which is basically RFT, renal function test, serum calcium phosphate, uric acid and magnesium, serum alkaline phosphate, urine sample which includes microbiome culture, 24-hour urine sample, stone analysis, IVP dietary. So this is all about it, and yep, that's about it. So usually if the stone is more than 2 centimeters, we go for extra extracorporeal shockwave lithotripsy, and depending on the position of if it is more than 5 centimeters, we go for PCNL. So basically, depending on even on the position of the stone, it can be divided into many things, such as um, if the stone is located in the renal calculi and it is more than 2 centimeters, PCNL is advised, and if the calculi is less than 2 centimeters, ECSWL is advised, and if it is in the upper half of the urinary tract, and if it is more than 1 centimeter, if it is more than 2 centimeters, then if it is more than 3 centimeters, then PCNL, and if it is less than 3 okay, note, I'll just suggest I'll give a table later, but for now, that's about it. And I think that should summarize the ureteric colic for nephropathy.